All right, Dr. Morgan, I think we are good to go. We are ready when you are. Thank you.
Thank you very much, and welcome everyone to the Hindsight 2023 Years of Public Health Emergencies. Can you believe we are here at this 3-year mark? The National Hispanic Medical Association is sponsoring with Vaccinate for All, and we absolutely are grateful to our sponsors from the CDC and the AARP. We have a great panel tonight with Amilda Medina, Bertha Hidalgo, and Doug Jacobs. So sit back and we'll be listening to all of them speak today. Just a little housekeeping. All of the participants' microphones will be muted, but please put your questions in the Q&A box for the panelists and we will do the best that we can to address them at the end of the program. Also, wait until the very end because we have a very short post-webinar survey for you to fill out, and there is a prize to be won at the end for filling out this survey via a raffle. Also, everything will be recorded and live streamed today, and you will have access to it afterwards as well. Just a couple of updates. The FDA is expected to decide on the PDUFA goal date in May of 2023, and this will be whether to approve Pfizer's vaccine for RSV in adults ages 60 and older. The public health emergency for COVID-19 will expire on May 11th of this year. And once Medicaid terminations resume, the majority of those who will lose coverage will be people of color. So that's over 4 million Latinos, 2 million African Americans, and over 5 million children will lose Medicaid, 3/4 of whom will remain eligible but terminated for admin reasons. Vaccination in the Latino community is still a problem. Hispanic people have been less likely than their white counterparts to receive a vaccine, according to the Kaiser Family Foundation. There's a desperate need for improved, culturally and linguistically appropriate interventions. We have resources available and make certain that you access these resources either now or after this presentation. So there's a COVID-19 resource center via the aarp.org, coronavirus and L coronavirus, and then valuable articles for considerations, the AARP on prescription drugs, the symptoms of long COVID, what to know about the coronavirus vaccines, what you need to know about the coronavirus, and how to find coronavirus help in your state. So we'd like to start today, and maybe I should just take a moment just to introduce myself as well before we go on to Dr. Doug Jacobs. So I'm Dr. Jayne Morgan. I am a cardiologist, but also lead the COVID task force at Piedmont Healthcare for the last 3 years. We're the largest healthcare system in the state of Georgia. We service about 75% of the population. We have 37,000 employers. It makes us one of the largest employers here. And so as we have moved forward in COVID, we certainly have experienced within this health system lots of ups and downs. My background comes through Solvay Pharmaceuticals and Abbott Pharmaceuticals. So I come through the drug and device industry and have spent a great deal of time in research and certainly have published as well throughout this COVID pandemic. So our first speaker and presenter today is Dr. Doug Jacobs. He's an MD, MPH, the Chief Transformation Officer for the Centers for Medicare and Medicaid Services. At CMS, he's helping to lead Medicare's efforts to promote value-based care, advance health equity, and encourage delivery transformation. He most recently served as the Chief Medical Officer and Chief Innovation Officer for the Pennsylvania Department of Human Services, helping to oversee the state Medicaid and Human Services programs amidst the pandemic for the 16,000 person state agency. He was tapped by Governor Wolf to lead the state's whole person health reform initiative, which included expanding value-based care, promoting health equity, and addressing the social determinants of health. Under his leadership, the Department of Health Services created Pennsylvania's first equity incentive program in Medicaid, established new rules incorporating community-based organizations to address the social determinants of health, and oversaw Medicaid's increasing movement towards value-based care. He also helped lead the COVID-19 response for the agency, creating programs to protect long-term care facilities and roll out the COVID-19 vaccine to vulnerable populations. Dr. Jacobs is a practicing, board-certified internal medicine physician and is an assistant professor of clinical medicine at the Penn State Hershey Medical Center. He's also an avid writer, having published pieces in the New England Journal of Medicine, Journal of the American Medical Association, New York Times, and Washington Post. He trained in internal medicine residency care at the Brigham and Women's Hospital and served as chief resident at the West Roxbury, Virginia Hospital, receiving his MD at the University of California, San Francisco School of Medicine, and his master's in public health at the Harvard T.H. Chan School of Public Health, and his bachelor's in sciences from Brown University. Dr. Jacobs, welcome.
Thank you so much, Dr. Morgan. It's really a pleasure to be here with you all today, and happy to talk about sort of looking back, thinking about what we've learned from the pandemic and how we can move forward as well. And thanks to everyone on this call who I know is doing such important work related to vaccination and improving some of those disparities that we see as well. I'm in Medicare, and Medicare is responsible for more than 20% of all dollars spent on U.S. healthcare. The effects of our actions often ripple throughout the healthcare system. Our priorities in the Center for Medicare are advancing health equity, moving to high-quality, person-centered, value-based care, implementing the Inflation Reduction Act provisions, including drug negotiation in Medicare, engaging our partners, especially people with Medicare, and expanding access to behavioral health. And many of these topics I'll kind of touch on today in my remarks. So CMS plays an important role in protecting the health and safety of all Americans as they journey through our healthcare system, and that's especially true during a pandemic or other emergency. During the COVID-19 public health emergency, CMS has used a combination of emergency authority waivers, regulations, and other guidance to ensure access to care and give healthcare providers the flexibility they need to respond to COVID-19 and help keep people safe. Many of these waivers and broad flexibilities will terminate with the PHE on May 11th, as they were intended to address the acute and extraordinary circumstances of a rapidly evolving pandemic and not necessarily replace existing requirements. So we're making a very conscious effort to get information to everyone that will be very useful as we continue to approach that May 11th date. We began preparing for the end of the PHE a while ago and have provided ongoing information regarding flexibilities that will end or have been made permanent. You can find this information through our website at cms.gov. So no need to take detailed notes of what I'm saying. So once there, you just click on COVID-19 and you'll be taken to an emergency page to find out our latest information. Over the course of the PHE, we've learned a great deal from healthcare providers, facilities, insurers, and other stakeholders' experience in the use of waivers and flexibilities. So I'd like to take a few minutes to give you some examples of what CMS has learned during the pandemic related to Medicare payment for vaccines and testing, behavioral health, and then also moving to high-quality value-based care. I'll also discuss what CMS did as a result and how we can think about moving forward. So first, to start with vaccines and testing. Over the last 2 years, the Biden administration has effectively implemented the largest adult vaccination program in U.S. history, with nearly 270 million Americans receiving at least one shot of COVID-19 vaccine. As a result of this and other efforts, also efforts from many of the folks on this call, since the peak of the Omicron surge at the end of January 2022, daily COVID-19 reported cases are down 92%. COVID-19 deaths have declined by over 80%, and new COVID-19 hospitalizations are down nearly 80%. There's of course still work to do, including in the disparities realm. So thanks again for working on all of this together. So CMS will continue to pay approximately $40 per dose for administering COVID-19 vaccines in most outpatient settings for Medicare beneficiaries through the end of the calendar year, in which the Secretary ends the emergency use authorization for drugs and biologicals with respect to COVID-19. So that means at least through 2023. This EUA declaration is distinct from and not dependent on the PHE for COVID-19. And so through the end of 2023, CMS will make additional payments to administer COVID-19 vaccines in the home, including individuals in smaller group homes, assisted living facilities, other types of group living situations. Some people have great difficulty leaving their homes or cannot easily access vaccination in these settings. And I've seen this firsthand from my own practice. These individuals are often at risk. And so making these additional payments for in-home vaccinations can help better serve these folks and improve health equity. And so also, as long as the government provides COVID-19 vaccines to healthcare providers under the CDC's COVID-19 vaccination provider agreement, the vaccines are free and available to all beneficiaries. So when healthcare providers are purchasing the vaccine, people with Medicare will continue to be able to receive COVID-19 vaccines and pay nothing if their doctor or other qualified healthcare provider accepts an assignment for giving the shot or is in network with a Medicare Advantage plan. Access to medically necessary lab tests will also continue without cost sharing when the test is ordered by a physician or other clinician. However, the program that currently provides people with Medicare free over-the-counter tests will end when the PHE ends on May 11th. So next I wanted to talk about behavioral health. We've learned a lot from the pandemic, and especially that we need to strengthen and advance behavioral health. As we all know, COVID-19 has really laid bare the nation's struggle with mental health and substance use disorders, fueling a full-blown crisis. And that's why CMS has issued our own behavioral health strategy, seeking to adopt a data-informed approach that removes barriers to care and services and promotes person-centered behavioral health care, including emotional and mental well-being. In both traditional Medicare and Medicare Advantage, we're mobilizing the behavioral health workforce, improving access, supporting high-quality care, and addressing the nation's substance use disorder crisis. I'm just going to highlight some behavioral health items. Number one, we've created changes to expand access to telehealth services for behavioral health permanently throughout the pandemic, and permanently after the pandemic, and also including audio-only services for people who lack access or are unable to use video. And this policy improves access to behavioral health services for everyone, and especially our most underserved individuals. In Medicare Advantage, we have new wait time standards for behavioral health and primary care, and also more specific notice requirements from plans to providers when these providers are dropped mid-year. We're also trying to mobilize the behavioral health workforce as much as we can. So we've changed the supervision requirements for behavioral health services in traditional Medicare, meaning that behavioral health practitioners can practice more at the top of their license, even if a physician or other non-physician practitioner isn't on site. We also added the network adequacy requirements in Medicare Advantage, licensed clinical social workers and clinical psychologists. And finally, we're created new payments for behavioral health clinicians like clinical psychologists, licensed clinical social workers, to provide behavioral health care as part of primary care, because most people access their behavioral health as part of primary care. And we're also creating new requirements in Medicare Advantage to create behavioral health care coordination programs to make sure that Medicare Advantage plans are really taking into consideration all of a person's needs, physical health, behavioral health, in the context of that person's life journey. And lastly, the third piece that I wanted to touch on is changing the way that care is delivered through this person-centered, accountable, and value-based care. The pandemic accelerated innovations in telehealth and care in the home, and it also proved that better care coordination, providing care not just within the four walls of a hospital or office visit, but also just thinking about the experiences of that person is really key to keeping people healthy. And accountable care is when a doctor, a group of providers, or hospital is responsible for improving quality, care coordination, and health outcomes for a group of patients. It reduces fragmentation and unnecessary costs for the healthcare system. And it can lead to more satisfied, better informed patients, fewer medical errors, better health, and more affordable care. And so we've created a number of changes to really advance accountable care. We're creating new advanced payments for new smaller ACOs that are forming. We especially want ACOs to form in rural or other underserved areas to make sure that there's no inequitable access to ACOs. And we've also made some changes to make sure that we're rewarding ACOs when they deliver high quality care to underserved beneficiaries in particular. And so it's for these reasons that our goal is to have every traditional Medicare beneficiary in an accountable care relationship with their provider by 2030. I also just want to touch on a few items related to telehealth. As we know, the pandemic really accelerated the use of telehealth. During the public health emergency, it led to such a significant rise in telehealth, about a 63-fold increase per an HHS report. And as a physician, I've just seen also how telehealth has benefited my patients and allowing them to access care in their home. And so Congress recently extended several telehealth flexibilities for Medicare, and this is under the Consolidated Appropriations Act of 2023. So through the end of 2024, people with Medicare can access telehealth services in any geographic area in the United States, and not just in rural areas. People with Medicare can stay in their homes for telehealth visits, and Medicare will pay rather than having the provider travel to a healthcare facility. Certain telehealth visits can be delivered audio only, such as just a telephone, if a person is unable to use both audio and visual technologies like a smartphone or a computer. Medicare Advantage plans may offer additional telehealth benefits, and so you should check with your plan. And for Medicaid and CHIP, telehealth flexibilities are not tied to the end of the PHE and have been offered by many state Medicaid programs long before the pandemic. And so coverage will ultimately vary by state, but we're encouraging states to cover services via telehealth. And CMS has also recently released state and Medicaid and CHIP telehealth toolkits to identify for states certain policy topics that should be addressed to facilitate widespread adoption of telehealth. And in private insurance also, it varies by the plan after the end of the PHE. So it's important to check with plans as well. I know I'm coming to the end of my time. I just want to touch at the end here. So like, where do we go from here? We're really trying to develop this comprehensive and long-term approach to make sure that we have a resilient healthcare system. And so we've developed a roadmap for the end of the Medicare PHE waivers and flexibilities. I shared some links to the folks who organized this conference. So I think, and I mentioned that you can look on that COVID-19 emergency page. Look there for updated guidance as we get closer to the end of the PHE on May 11th. And as always, we'll continue to engage the healthcare community to share feedback and also collaborate to provide that person-centered, safe, high quality and equitable care that Americans expect and deserve. So thank you so much again for having me here today, and look forward to the question time too.
Thank you so very much, Dr. Jacobs. We will continue on now with our second speaker, and this is Amilda Medina, and she's a PGY2 HSPAL pharmacy resident at Novant Health Forsyth Medical Center. Dr. Amilda Medina is a PGY2 MHA Health System Pharmacy Administration and Leadership HSPAL resident at Novant Health in Winston-Salem, North Carolina. Originally from Houston, Texas, Dr. Medina attended the University of St. Thomas University as a first-generation college student, where she received her Bachelor of Science in Biology and a minor in Spanish in 2015. In 2020, Dr. Medina earned her Doctor of Pharmacy degree from the University of Houston College of Pharmacy before going on to complete residency. Welcome, Dr. Medina.
Thank you, Dr. Morgan, for a wonderful introduction. So for my part of today's presentation, I just wanted to touch upon our COVID vaccine status with the Hispanic population, and where do we go, where are we currently standing, and what are the next steps that we need to take as we proceed to our end of the PHE. So next slide, please. So again, my name is Dr. Amilda Medina. I'm currently a second-year pharmacy administration resident at Novant Health Forsyth Medical Center. Next slide, please. So next slide as well. So again, as it was mentioned, on May 11, 2023, we are arriving at the end of our public health, COVID-19 public health emergency. which means that there will be several changes that will take place as it was mentioned by Dr. Jacobs. So next slide, please. So go ahead and move fast forward towards the next one, since we've kind of already covered this, and just to leave time for everyone to ask us questions. But really what's one of the things that's not ending is vaccine coverage. So although we are ending the PHE, vaccine coverage is still something that will be remaining, which will be the focus of my segment. So next slide, please. So where are we now? So on this next slide, I have information from the Kaiser Family Foundation. This was information that was gathered as of July 6, 2002, which is showing us the number of people who have received at least the first COVID-19 vaccine. So I wanted to point out the Hispanic population. And as you click, can you go ahead and click next? So then, right, thank you. So there has been 21% of our Hispanic population who has received at least one dose as of July 6, 2022. Then for the patients or people who have initiated their vaccination in the last 14 days, around that time, there was 23%, with a total number of 19% of the Hispanic population receiving the COVID-19 vaccine. But this is just for at least one dose. When we're looking on the next slide for information regarding the booster dose, for people who have already received the booster dose, we have 15% of the population being of the Hispanic population. People who have received a booster dose in the last 14 are 23% as of July 6, 2022. And then importantly, about 20% of our Hispanic population in the US has been fully vaccinated with the COVID-19 vaccines and all the booster doses. So then this leads us to the question, what are some of the barriers that we've encountered when it comes to getting the COVID-19 vaccination, and why is this the current rate that we have? So in the next section, I have listed reasons for non-vaccination that has been collected through many different research studies that have taken place. So some of them are concerns about side effects. Many people are just worried about any potential side effects that they might be hearing from the media, or they might be hearing from others regarding the COVID-19 vaccine. Other causes include religious beliefs, the belief that it is not necessary, any safety concerns about vaccine contents, beliefs that it does not protect them from COVID-19, or technology barriers such as not being able to sign up for a vaccination. Previous slide, please. Thank you. In addition, as mentioned, one of the common barriers that we're seeing is lack of transportation to vaccination site, along with cost, although most COVID-19 vaccines are free of charge. Other reasons for non-vaccinations has included that there might be just difficulty getting time off from work to go get the vaccine at one of the clinics or pharmacies. I believe that mainly around them have already received the vaccine, so they don't see a need for that individual to obtain a vaccine as well. And then some have received medical exemptions. On this slide, I've included the top 3 reasons that I've came across, which are the ones that are depicted by the star. So moving on to the future considerations. What are some things that we still need to consider thinking about as we move on towards the end of our PHE in May 11, 2023? So in the next slide, I have those considerations. The first one is cost and access to care. Before COVID-19 and during, and now that we're going post COVID-19, this still remains one of our top concerns and priority when it comes to our patients. Everyone is still, this is still something that we have to keep in mind. The next thing is the COVID-19 vaccine status. So as I showed in the previous slides, we still have a lot of work to do within our Hispanic population in getting those vaccine rates increased in the next couple of months and years. In addition, there's going to be a lot of work that still needs to happen to continue to break down barriers that lead to those difficulties that I previously mentioned in achieving access of care. And a lot of our work will also be to continue to work on increasing our patient education and disease state awareness. As it's commonly known that one of the disproportionate shares of the Hispanic population is our poor health literacy Statistics shows that 41% of the Hispanic population in the US has a low literacy level. So it's very important for us as healthcare providers to remember this and consider this as we continue to work on increasing that health literacy and talking to our patients, promoting the COVID-19 vaccine. So with that, I want to go ahead and thank you all for joining us today, and pass it on to our next speaker for today. Thank you.
Very much, Dr. Medina. So next we have Dr. Bertha Hidalgo, and she's the Associate Professor, Department of Epidemiology at the University of Alabama at Birmingham. Dr. Bertha Hidalgo is an Associate Professor at the University of Alabama and holds degrees from Stanford University, the University of Southern California, and the University of Alabama in Birmingham. Her research focuses on health inequities related to COVID-19, cardiometabolic diseases, with a special focus on Latino populations, genomics, and dissemination science. She leads DEI efforts at the University of Alabama, including serving as director of the Driven program and nationally as a voting member of the NCATS DEI task force. Welcome, Dr. Hidalgo.
Thank you so much, Dr. Morgan, and thank you all for having me today. I want to apologize for the lack of video. I am calling in from sunny now, Los Angeles. We had some weather this morning, but true to my Latino parent home, we have zero internet, which means that I'm calling from my cell phone. And could not find enough signal apparently to host video today. So I appreciate everyone's attention to my voice as I present the following points, which from my perspective as an epidemiologist, really I think provide a good synopsis of what we've observed epidemiologically over the last 2+ years. So if we'll go to the next slide in the first point, please. So the last 2 years, we've learned a lot about COVID-19 from a myriad of perspectives, but I think overwhelmingly what we have seen is that there was a disproportionate impact on racial ethnic communities, especially Hispanic Latinos. Is that me? I think someone's not muted.
Yes, please, if everyone could mute. Thank you. Please go ahead, Dr. Hidalgo.
Thank you so much. And what we saw was that COVID-19 disproportionately affected these minoritized groups. There were higher rates of infection, higher rates of hospitalization, higher rates of death. These groups largely included African Americans, Hispanics, and Native Americans. And what we've seen, and I think pertinent to today's discussion, is that these groups not only had higher rates of infection, hospitalization, and mortality compared to white Americans, but that the reasons for these disparities are really complex. They're multifaceted, and they really include factors such as structural racism, discrimination, poverty, lack of access to healthcare, and really a true underlying of a myriad of health conditions that have affected people from recovering swiftly from the COVID-19 disease that afflicted them. And I think pertinent to today's discussion as well is the fact that among Latinos, what we also observed is that these rates disproportionately affected this next point. Please click to the next, to number 2. Which is that we saw a high risk, especially for individuals that were essential workers. And in this category, a lot of Latinos fall under the essential worker category and or status, which means that if you'll recall early on in the pandemic, many persons that were considered essential workers were first in line to go back to the workforce. And in some ways to this day, there aren't full-fledged recommendations for workplaces to be able to provide worker protections, especially for people that are of essential worker status. That has changed in some workplaces, but early on in the pandemic, many people went back to work, especially Latinos, with little protections in place. And I think that especially if you recall, somewhere between March and April, we still did not have wide adoption of the mask wearing and or masks at all. We've learned a lot since then about air quality and the benefits of having clean air in workplaces because COVID-19 is a disease that spreads through the air. And so there was a significant impact on essential workers that really led to a higher risk for those individuals as they went back to work. Next slide, please. We also saw significant disparities in access to healthcare. Individuals we know with lower income, less education, potentially unstable housing are more likely to experience barriers to healthcare access, including lack of health insurance, transportation, and language barriers, as were highlighted by the last two panelists. And I think that what we have also observed with this point is that there was also a fear of accessing healthcare spaces because it was unknown if people would acquire the disease if they went for other conditions. And so people delayed mammograms, they delayed wellness checks, they delayed a number of visits to the doctor, dentists, and other healthcare professionals for fear of becoming infected with COVID-19. And we are now seeing the repercussions of those delays through increased rates of other diseases and adverse healthcare outcomes. Next point, please. We talked a little bit about how pre-existing conditions or underlying health conditions also exacerbated risk for COVID-19. We know that individuals with pre-existing health conditions such as diabetes, heart disease, and obesity are at high risk for severe illness and death of COVID-19. These conditions are more prevalent among marginalized and disadvantaged communities, which do include Latinos. And I don't think that we appropriately disseminated information about this. There is a lot of unknown status of these types of conditions in Latino communities because there is a lack of access to health and healthcare and a lack of access to information about what these diseases mean. A lot of people may not have diagnosed diabetes condition or a diagnosed hypertensive condition, which may predispose them for adverse outcomes from COVID-19. Next point, please. Latino populations, but not only Latinos, a lot of minoritized communities are communities that live in overcrowded housing. This may mean either living in places where multiple families live in a single unit, or where families live in units that are a part of a bigger structure like apartment buildings and other such structures. And what this meant during the COVID-19 pandemic was that if someone got sick, for example, it was really difficult to isolate from the individual who was affected with the virus, who was infected with the virus. And as such, it was much easier for the disease to spread throughout families, in some cases leading to multiple deaths within a family within a matter of weeks or months. We saw this in my own family as we had individuals that suffered from the disease, and over the course of months, in two cases over the course of weeks, lost individuals to COVID-19 as a result of being unable to separate from those loved ones that they lived with or worked with. And so the housing status, I think, was a significant factor in being able to control the spread of disease, especially during those peak times when COVID-19 was spreaded rapidly throughout our communities. Next point, please. Access to testing was another significant barrier that we experienced. I think initially there was a stigma that was attached as well to testing positive for COVID-19. It felt a little bit like wearing a scarlet letter in your community. And I think that we initially failed to appropriately communicate the benefits of testing early identifying the disease so that we could isolate if possible, and then taking appropriate action to prevent the spread of the disease to others, of this virus to others. And then as time progressed, there became a little bit less of a stigma. However, still, I think with the advent of rapid testing, which was fantastic, the availability of having a rapid test at your home really changed the game. But really what it also did, however, was slow down the testing that happened at larger sites, the need to test so that people understood whether or not they needed to return to work, for example. And without protections for time to recuperate at home, it also proved very difficult for people to test positive, because knowing that they were positive meant that they might have to take time off work without pay. Next slide, please. This limited access to personal protective equipment is near and dear to my heart, as I did a significant amount of science communication around COVID-19 over the last few years. And we've learned a lot about what PPE is and what it is not, which PPE is effective, which is a little bit less effective. And what we learned was that the better the mask, the higher the likelihood that one would be protected and protect others against the spread of the virus. And so what did that mean? That meant that masks like KN95s, surgical masks were probably among the higher tiered, N95s were the higher tiered quality masks that people should wear, especially in highly dense or closed areas with poor ventilation. However, these masks are quite expensive. N95s can run you anywhere between $8 to $10, maybe a little bit more, depending on the mask, per mask. And so you can imagine someone who needs it day after day for work situation, or potentially to be around someone who is immunocompromised or is a high-risk individual in a home, that it could be cost prohibitive to try and get this type of PPE. And that cloth masks, while they are also an option to wear as PPE, were less effective against the spread of COVID-19. And so that we needed to really be very intentional about how we were communicating the quality of masks for what situations and for what people. And we know that the higher quality masks, because of that cost, were posing a barrier to access for persons who had lower income or who could not really attain these in the quantities that they need them in order to keep themselves and their families safe. Next point, please. We talked a little bit about language barriers, language proficiency, especially when it comes to English proficiency. And what we've learned is that individuals who did not speak English as their primary language may have limited access to information about COVID-19 and also limited access to healthcare due to these language barriers. I think this last point has been proven in the scientific literature year after year. I personally observed the limited amount of information related to COVID-19 that was evidence and fact-based, that was primarily disseminated in English language, and that anything that was not English language really suffered from a quantity of information that was available to share via media, via social media. But however, what we did find was that there was a significant amount of information that was being shared that could fall under the misinformation, disinformation, and malinformation categories, which I'll get to in a bit. Next slide, please. We all know that there are significant mental health impacts from this pandemic. I think that, what do they say? It's, in hindsight, we wish that we could have done things differently. The pandemic definitely led to increased stress and anxiety, which definitely disproportionately affected marginalized and disadvantaged communities significantly due to pre-existing social and economic stressors. We know that the pandemic shined a bright light on existing disparities, but also the gaps that exist with respect to affordability, to access, and a number of other factors that really contribute to a person's health. And so moving forward, I love some of the points that some of the panelists have shared with respect to where we were and where we're going next. And I think that the discussion, I hope, will lead us in a direction to better plan for what comes next now that we understand more, not only about this virus, but how we prevent it and other communicable diseases as well. Next slide. I think anybody who has a child or has been close to a child in the last few years has also experienced some of the disparities experienced are due to education or that have afflicted education. We now know that school closures did not equally affect or benefit individuals across the U.S. equally. And in some cases, school closures did disproportionately affect low-income students and students of color who may have had lack of access to remote learning tools, support, and teachers. I think that in some communities, we also lost a lot of teachers due to COVID-19. Children also lost caretakers to COVID-19, which also affected their education, their stability in order to remain active learners in educational settings, even if remote. And so it was a multifactorial effect that the pandemic had on these children's education, both from a social network perspective as well as from a resource-based perspective. Next slide, please. So this is the last point that I'll cover, and then I think we're going to go to Q&A. The misinformation aspect of this pandemic is really a pandemic in and of itself that ran in parallel to the pandemic that was caused by the virus that causes COVID-19. The influx of information that is on social media, on the internet, related to this virus, about the virus, the disease that it causes, is numerous. And overwhelmingly, I think, has really disrupted our ability and people's ability to discern fact from non-fact. And it has affected people's decision making. We heard a little bit about some of the reasons why people do not get the COVID-19 vaccine. There are individuals who may have started the series, for example, gotten a dose 1 and 2, but then heard and were convinced by mis or disinformation, potentially even some information that falls under malinformation, and have refused and or discontinued to pursue getting additional doses of the vaccine that can provide additional protection, especially now that we have new variants that have come to circulate in our communities, and that we really need that protection in order to have the best chance at having better outcomes if infected with the virus that causes COVID-19. So to me, misinformation is one of the very significant factors that has affected our ability to come out of this pandemic with fewer lives lost than we have. I have not touched on long COVID, but I think there is also a lot of misinformation around what COVID-19 is and is not, including how severe it is. We now know that underlying health conditions not only disproportionately affected individuals who had them for adverse outcomes for COVID-19, but that also it may have contributed to an experience of long COVID symptoms where people do not recover immediately. We know also, however, that long COVID may affect individuals that did not have underlying conditions. And so it is definitely a point of contention, one that misinformation is really circulating around. So with that, I think I'm going to close and open up to our moderator, and thank you all for really continuing to be attentive to COVID-19 and for listening to to me today without video. Many thanks.
Really, thank you very much. And if all the speakers could maybe come back up on video, I know Dr. Hidalgo, you're not able to, and maybe we can start with Dr. Jacobs with regard to what are the options for the uninsured after the PHE ends on May 11th? And you have to come off mute. Thank you.
Hey, thanks so much for that question. So, of course, and as Dr. Hidalgo just mentioned, being insured is a very important social determinant of health. Like being insured is associated with getting needed preventative care, going to see your doctor more regularly, and so it depends on the individual, like what kind of insurance they would qualify for. Maybe they still qualify for Medicaid. Maybe they'll qualify for Medicare if they are disabled or if they are above age 65. Or maybe they qualify for a plan on the marketplace in your state or on healthcare.gov, depending on the state. So it really does depend on the person who doesn't have insurance. But we're trying to make it so that there's really options for everyone, hopefully that are affordable to them.
Yeah, thank you so much. And Dr. Medina, another question. According to the Kaiser Family Foundation, Hispanics make up 19% of the US population and 23% of people who've received at least one dose of the vaccine. It seems that they're doing better than any other ethnic group. Is this correct? What can we attribute to this so that we can possibly incorporate the strategy with others? I know they lagged initially, but this changed in 2021, 2022. You can come off mute. I think you're on mute.
Thank you. Yeah, I was clicking the button. I know we, in the Hispanic population, we initially struggled a lot with the COVID-19 vaccine. A lot of it came because of what we were talking about, misinformation, fear of, this is, how much is this going to cost me? Will I be able to afford this? And a lot of the work during this time, I was a CVS pharmacist and I was immunizing. A lot of the work was breaking down that misinformation and making sure that we're providing the community with the right information and the right access, and getting rid of those myths that were circulating at that time. I think that really helped us make a big push. Something that's very interesting with our Hispanic and Latino community is that we have a sense of familiarismo. So which means that like we're very tight-knit, and if we have like this very sense of family members. So like, for example, if for my family, my family at first, some of them were resistant, some of them were not. But as they started to see the majority of us going and getting the vaccine and seeing how everything was working out fine, that helped us build up that trust and use our tight-knit relationship to continue to influence others to get the vaccine. So at the end, after a couple months of it was discussion within my own personal family, I was able to get all my family members to my so I was like, hey, I'll be the one giving you the vaccine too. So work like that has really helped. One of the things that we are very big in our culture is religion. So I remember going to local community leaders and talking to our priests and like, can I have a second we went to virtual, so during the mass, to just talk about the vaccine and answer any questions that anyone might have. So a lot of efforts that went like that throughout, all this happened throughout the nation, not just in Houston where I was at the time, really helped us move the needle forward. And tackling those barriers that we were discussing today is the key to continue to push our numbers in the right direction.
Yeah, wow, thank you very much. And Dr. Hidalgo, how can we continue to provide accurate and timely information to communities of color now that people might think COVID is over since all the emergency orders are ending?
Yeah, thank you for that question. I think it is one that I have pondered myself. I worry that we have created communication silos to some extent because there was existing mistrust in our communities entering into the pandemic, medical mistrust for all of the injustices that have happened on many of our communities throughout the history of medical care, which were exacerbated over the last 2 years for a variety of reasons related to COVID-19. They have affected how we view COVID-19. They have affected our ability to want to get the COVID-19 vaccine. They have affected how we view treatment for COVID-19. They have affected how we view transmission of the virus that causes COVID-19. So what do? We learn, I think, from the people who are so skilled at sharing non-evidence-based information. And we gather together, I think. For those of us that are in this room virtually who do community-based participatory research, we have many models that we can adapt, like the community health worker model, like the patient navigator model, where we really take, I think, people from the community who serve the communities to empower them with the information that is accurate and evidence-based in order to disseminate in a way that is person on person, because nobody cares if I have a PhD or whatever letters behind my name. What they want to know is from the person sitting next to them, is the information that they're sharing something they're willing to believe? And my research, based on evidence-based information that is shared on social media, is that they will believe the person they trust. So who are the people they trust? And those are the people that we use to share these messages and this type of information. So we have to become better listeners, I think, of what is happening and who needs this information, and then use the trusted sources within those communities to be sharers of this trusted information.
Thank you very much. And Dr. Jacobs, regarding continuing vaccination, has anyone incorporated vaccination into primary care settings instead of massive vaccination sites? Have we thought about that?
Yeah, absolutely. So just to build off of what the other panelists have been saying, I think what you're hearing is a consistent focus on who the messenger is, and the benefit of vaccination through primary care providers is oftentimes a primary care provider is that trusted messenger for a patient. Now, sometimes they're not, but sometimes they are. And so oftentimes primary care doctors have arrangements. They get vaccines, and those vaccines can be delivered under the CDC arrangement. Those vaccines are all free. And so absolutely incorporated into primary care. There's just to echo what the others have said, like using community health workers, getting out into the community, finding who those trusted messengers are, and saying, hey, can we work together to deliver this important message to the community? It's why the community health worker model really shows strong impacts. Promotores de salud, oftentimes in Hispanic communities. I think there's so much that can be leveraged in terms of just using the networks and trusted messengers that people have in their lives on a daily basis.
Thank you very much. And Dr. Medina, what efforts are being made to determine the incidence of long COVID in Hispanic and Latino populations in the U.S.? And really, if someone else wants to answer the question too, jump right in. And I think you're on mute.
Sorry, I'm not familiar with long COVID. I'm not sure.
Okay, so that's perfectly fine. Dr. Hidalgo.
Yes, sure. Thank you. That's a great question. And there are multiple efforts that are ongoing, including the NIH Recover study, which is actively enrolling individuals who have never had COVID or who have had COVID to better understand how long COVID develops in persons that have had a SARS-CoV-2 infection. What's really difficult, I think, about long COVID is that there is no magic formula for diagnosing long COVID, and long COVID appears to be different in different individuals. And so the myriad of symptoms, or the type of symptoms that individuals may experience over the course of months to years after having an initial SARS-CoV-2 infection that leads to COVID-19, may vary significantly and may in fact be dismissed as other diseases or symptoms in clinical settings. And so I think even in the clinical setting, there's not general agreement with respect to what long COVID is yet. I think we're getting better at defining what long COVID is. I think the NIH Recover study will provide a lot of insight into what needs to be seen in clinical practice and how patients can advocate also for themselves with respect to what they're experiencing. But, NIH and CDC and others have done a great job of sharing information about what long COVID may be, including, for example, fatigue that does not go away, tinnitus. I think some people feel things like vertigo or dizziness. So finding more information about things like that, especially for persons who may have some symptoms that have not resolved after a known COVID-19 infection, is good to share with their primary provider and share more information about this widely so that greater knowledge and awareness is raised about what long COVID is and that it does exist and it's out there.
Sure. And Dr. Medina, what steps can healthcare providers take to ensure equitable access to COVID-19 vaccines in underserved communities?
I think it's continuing the efforts that we've done already. Again, I feel like I'm going to repeat myself a lot, but it's like going to like understanding what are the barriers our Hispanic population are facing and what the healthcare providers to break them down. I think we've learned a lot these past 3 years about what they are, and some of them we've known before COVID, and also understand that this is still going to be barriers and that are still going to affect our Hispanic population beyond COVID. So now that we know this information and taking everything that we've learned over the past couple of years, what can we do to continue the work that we're doing? It's going to be a lot of work, but I think it's something that's very possible, and working together within the different professions as we're talking about our patients, as we're all caring for them in our own respective settings, but just getting together and working to be able to break down those barriers and continue to increase access of care for our underserved population.
Yeah, great answer, and important to enforce. Dr. Hidalgo, there is a question about pregnant women who are unvaccinated and at high risk, and how can vaccine confidence be improved in this very specific vulnerable population?
Yes, also another such important question because it is a especially vulnerable population. There was a lot of advocacy that was done to be able to include pregnant persons in vaccine trials so that we would have the evidence to be able to share with this population so that there would be increased confidence in the vaccine. What we now know is that individuals who experienced COVID-19 disease during pregnancy did have a significantly elevated, much higher risk for adverse outcomes, including mortality, as a result of COVID-19, not only for the pregnant person, but also for the babies, and that the babies also experience not only mortality, but significant adverse health outcomes if they were born to a person who is infected with COVID-19. And so what's really difficult about this is that people want to do the best for their babies. There is a lot of decision-making that is born out of fear, the fear for wanting to do best by their babies. And what we now know that is evidence-based is that COVID-19 vaccination provides the best shot at a healthy pregnancy and a healthy delivery and a healthy baby. And so the more that we can share that information in communities, especially Latino communities, the better. Before closing out, I just want to also say that part of what happens with Latino communities, but really any community that is non-English speaking, is that there is also a delay in when a term is identified, like long COVID, for example, and when an agreement to a definition is agreed upon in the non-English speaking language. And so there's also therefore a delay in evidence-based and fact-based information that is shared in those other languages that can then be with certainty disseminated to those communities. And so long COVID is one example, for example, where, it's called COVID persistente, which is like persistent COVID, which sounds a little bit different than long COVID, but same message. And I think with respect to vaccination during pregnancy, that there is a lot of misinformation that swirls around for that state of health in general. Add to that the uncertainty that exists around COVID-19. I think you're set up for a lot of barriers with respect to care.
Well, thank you very much. This brings us really to the end of a really prolific hour. I've certainly learned a lot, and I'm leading the COVID task force, so I hope you've learned a lot as well. Don't forget, at the end, we will have a survey that we would really like for everyone to stick around and fill out that survey and have an opportunity to enter into a raffle. We've got some updates with the National Hispanic Medical Association programs. The 26th annual conference is in Chicago next month, April 27th to April 30th at the Hyatt Regency, and the NHMA Vaccinate for All campaign website is launched at hispanichealth.info and vaccinateforall.org. Register for free to join over 200 plus individuals and organizations and be champions today. Again, we've got these QR codes up. You can scan them to make sure that you keep up with all the NHMA upcoming events as well as the programs update. We absolutely want to thank once again CDC and AARP for their generous sponsorship of this absolutely wonderful program. And here's your QR code again for your post-webinar survey and an opportunity to win a great t-shirt, Vaccinate for All t-shirt. Please fill out the survey, everybody. Have a wonderful evening.